Welcome. In this session we are going to discuss about ptosis, evaluation for ptosis, the various types of ptosis, and selecting among the treatment options for ptosis. Ptosis, more appropriately called blepharoptosis, is inferior displacement of the upper eyelid in primary gaze, and this results in superior and sometimes central visual field defect, astigmatism, decreased vision in dim light, and occlusion of visual axis if ptosis is severe. Ptosis can be classified by its etiology as neurogenic, neuromuscular, myogenic, aponeurotic, and traumatic. And ptosis can be classified by its onset, with congenital ptosis being most commonly myogenic and acquired adult onset ptosis being most commonly aponeurotic. We begin the evaluation of a patient with ptosis by inquiring about variability in the degree of ptosis which is found in myasthenia gravis, and also inquire about family history of ptosis because there are certain hereditary disease entities such as myotonic dystrophy and oculopharyngeal dystrophy in which ptosis is also found. Several eyelid measurements are taken to determine the etiology and severity of ptosis and to choose the most appropriate surgical treatment option. Margin reflex distance 1 or MRD1 is the distance between the upper eyelid margin and the corneal light reflex in the primary gaze position. And MRD1 can be negative if upper eyelid margin is below the corneal light reflex. MRD1 of the other eye should also be measured by lifting the ptotic eyelid so as to negate the action of the frontalis to unmask occult ptosis in the contralateral eye. The normal value of MRD1 is 4 to 5 mm, that is half the vertical height of the cornea. Margin reflex distance 2 or MRD2 is the distance between the lower eyelid margin and the corneal light reflex in the primary gaze position. It is decreased in Horner syndrome where there is decreased sympathetic innervation to both the superior tarsal muscle or the Muller's muscle as well as the inferior tarsal muscle, so that there is inferior displacement of the upper eyelid margin and superior displacement of the lower eyelid margin, and the superior displacement of the lower eyelid margin can be detected with MRD2. MRD2 is increased in lower eyelid retraction in situations such as following blepharoplasty. Vertical palpebral fissure height is measured at the widest point with the patient looking at a distance in the primary gaze position. Next, the position of the upper eyelid crease is measured. An upper eyelid crease represents the attachment of the levator palpebris superioris aponeurosis to the eyelid skin, and we measure the distance of the upper eyelid skin crease to the upper eyelid margin, and the normal position of the upper eyelid skin crease is 8 to 9 mm in males and slightly higher in females. However, it is lower in Asian eyes when compared to non-Asian eyes. What is more important is in involutional ptosis, the upper eyelid skin crease is higher than that in the contralateral normal eye. And in congenital ptosis, the upper eyelid skin crease is either shallow or absent, and this is very important to remember. Next, we measure the upper eyelid excursion, which demonstrates the function of the levator palpebris superioris muscle, and this is very important in determining the most appropriate surgical treatment option. The patient is first asked to look downwards, and the action of the frontalis muscle, the accessory elevator of the eyelid, is then negated with digital pressure over the eyebrow. The patient is then asked to look upwards, and the excursion of the upper eyelid margin is measured from the down gaze position to the up gaze position, and this should be normally more than 15 mm. And as we have mentioned, upper eyelid excursion determines the selection of corrective surgery in the two most common forms of ptosis. In acquired involutional ptosis, levator function is usually normal or near normal with upper eyelid excursion more than 4 mm, and this form of ptosis can be corrected with levator advancement or resection. In the other common type of ptosis, that is congenital ptosis, levator function is usually poor and levator excursion is less than 4 mm, and this type of ptosis requires Frontalis sling for correction. Lack of thalamus or an inability to close the eyelids completely can coexist with ptosis, and this increases the risk of keratopathy following ptosis correction. If present, lack of thalamus should be measured as the distance between the two eyelid margins with the patient attempting to close the eyes. Additional examination which should be done in a patient with ptosis include assessment of the tear film quantity and quality, assessment of corneal sensation, and checking for superduction of the eyeball during eyelid closure, which is also called Bell's phenomena and which can be deficient in congenital ptosis. These three are very important to prevent or reduce the risk of exposure keratopathy following ptosis correction. Lifting the ptotic eyelid makes the contralateral upper eyelid droop, because lifting the eyelid margin of the ptotic eyelid negates Frontalis action on both the sides. If the contralateral eyelid has pseudoretraction, lifting the ptotic eyelid margin makes the contralateral eyelid margin come to its normal position along the superior limbus or immediately below that. But if the contralateral eyelid is also ptotic, lifting the more ptotic eyelid margin makes the contralateral eyelid margin come to a final position much lower than the superior limbus. We can find synkinesis in Marcus-Gunn phenomena, which we have discussed in neuro-ophthalmology, in Duane's retraction syndrome, which we will be discussing in the strabismus section, and with aberrant regeneration of cranial nerve 3 or cranial nerve 7. Position of the ptotic eyelid in down gaze is very important to assess, both to differentiate the two common forms of ptosis as well as to exclude lack of thalamus prior to surgical correction of ptosis. In congenital ptosis, the ptotic eyelid is higher than the normal contralateral eyelid in down gaze, and this is very important to remember, that the ptotic eyelid is higher than the normal contralateral eyelid in down gaze. In contrast, in involutional ptosis, the ptotic eyelid margin is at the same level as or lower than the contralateral normal eyelid margin in down gaze. Visual acuity and refractive error is very important to assess in congenital ptosis to rule out amblyopia due to astigmatism or occlusion which can happen with the ptosis, or strabismus which can be associated with the congenital ptosis. In every patient with ptosis, extraocular muscle function and pupil reactivity must be assessed, because as we have discussed in the section on neuro-ophthalmology, examination of these three, extraocular muscles, pupils and lids, go hand in hand because of their common innervation from the third cranial nerve. Extraocular muscle dysfunction can be found with ptosis in congenital oculomotor nerve palsy and in combined maldevelopment of the superior rectus muscle and the levator palpebrae superioris muscle. Oculomotor nerve palsy can also be acquired, and acquired forms of ptosis along with EOM dysfunction can also be found with myasthenia gravis and chronic progressive external ophthalmoplegia. Ptosis along with pupillary abnormalities can be due to oculomotor nerve palsy as well as Horner syndrome, and the etiology behind them can be potentially fatal, as we have discussed in the neuro-ophthalmology section. Associated periocular abnormalities as found in blepharophimosis syndrome should be looked for, and demonstrating abnormalities in head position, chin elevation and brow position, and demonstrating brow elevation during upgaze indicates to the patient how ptosis affects function and how surgical correction may help. Visual field testing once with and once without elevating the ptotic eyelid demonstrates how the visual field is affected by the ptosis, and tests for myasthenia gravis and Horner syndrome should be done when they are suspected. After discussing the evaluation for ptosis, we now describe the various clinical types of ptosis, and the clinical types of ptosis described include myogenic, aponeurotic, neurogenic, neuromuscular, mechanical, and traumatic. Congenital myogenic ptosis, also called simple congenital ptosis, is one of the two common types of ptosis, the other being aponeurotic ptosis. And simple congenital ptosis is caused by maldevelopment of levator palpebrae superioris with fibrous and adipose tissue replacing muscle fibers in the muscle belly, resulting in decreased ability of the LPS to both contract as well as relax. Simple congenital ptosis is said to be usually bilateral but quite asymmetric, and we find here a clinical photograph of a patient with left-sided simple congenital ptosis. Clinical features of simple congenital ptosis include poor LPS excursion from down gaze to up gaze, lid lag in down gaze with or without lag ophthalmos, which is found in this patient, where in down gaze the ptotic eyelid margin is higher up in position than the normal eyelid margin. The eyelid crease is poorly developed or absent in congenital ptosis, and congenital ptosis may be associated with maldevelopment of the superior rectus muscle, and this results in poor bell phenomena with or without associated hypotropia in the primary position. Congenital ptosis can also be familial. Treatment of simple congenital ptosis is levator resection if the LPS excursion measurement is more than 4 mm, but with Frontalis sling procedure if the LPS excursion measurement is less than 4 mm. There are several forms of acquired myogenic ptosis which, though rare, are progressive in nature, making surgical correction difficult with recurrence of ptosis following surgical treatment. Chronic progressive external ophthalmoplegia is one such acquired myopathy, and in CPEO, a Frontalis sling is indicated only when vision is obstructed. Because of associated poor orbicularis function and also poor bell phenomena, patients with CPEO also has ocular surface dryness and thus requires additional lower eyelid elevation along with Frontalis sling for the upper eyelids. Oculopharyngeal dystrophy is an autosomal dominant entity with an onset usually in the 5th decade and presenting with symmetrical bilateral ptosis and dysphagia. Notably, the extraocular muscles are not affected. Myotonic dystrophy is also an autosomal dominant disorder with an onset between 2nd to 4th decades. Being a trinucleotide sequence repeat disorder, the onset is earlier and the disease is more severe in every successive generation. And myotonic dystrophy is characterized by an inability to relax muscles after sustained contraction. Myotonic dystrophy presents with symmetrical bilateral ptosis, meibomian gland disease, Christmas tree cataracts, temporal wasting, frontal alopecia, and distal limb weakness. Severe frontalis muscle weakness can occur in patients with severe myotonic dystrophy, and that may preclude even Frontalis sling surgery for correcting the ptosis. As in oculopharyngeal dystrophy, extraocular muscles are spared in myotonic dystrophy. Steroid eye drops and periocular injections can also cause a myogenic form of ptosis. Aponeurotic ptosis is overall the most common form of ptosis. It is an acquired ptosis which can be unilateral or bilateral and is caused by stretching, dehiscence or disinsertion of the LPS aponeurosis. It can be involutional or age-related or can occur following repetitive eye rubbing, prolonged use of rigid contact lenses, or following intraocular or eyelid surgery. In most cases, the LPS aponeurosis is still attached to the superior tarsus without disinsertion but is stretched. In aponeurotic ptosis, the upper eyelid skin crease is higher than that in the contralateral eye or may even be absent. The upper eyelid superior to the upper tarsus appears thin, and in aponeurotic ptosis, the excursion of the upper eyelid from down gaze to up gaze is usually normal, which is very important to remember. And this is because the LPS muscle is structurally and functionally intact. Often the ptosis is worse in down gaze, resulting in difficulty in reading. Neurogenic ptosis can be due to either oculomotor nerve palsy or Horner syndrome, and either can be congenital or acquired. Congenital ocular motor nerve or cranial nerve 3 palsy results in partial or complete loss of CN3 function, including meiosis, unlike acquired vasculopathic pupil sparing third nerve palsy. In congenital ptosis, aberrant regeneration does not occur, and in congenital ptosis, ptosis repair is associated with lag ophthalmos and diplopia due to associated palsy of the extraocular muscles. This will be mydriasis. In congenital Horner syndrome, there is a congenital defect in sympathetic innervation, including that to the superior tarsal or Muller's muscle as well as to the inferior tarsal muscle. As a result, there is a mild ptosis of the upper eyelid and elevation, also called reverse ptosis, of the lower eyelid. However, the LPS excursion is normal. Certain forms of congenital neurogenic ptosis also have synkinetic phenomena due to aberrant regeneration. Among them, there is Marcus-Gunn phenomena, in which there is elevation of the ptotic eyelid with movement of the jaw. When there is synkinesis between the external pterygoid and the LPS, elevation of the eyelid occurs with protrusion of the jaw, opening of the mouth, and contralateral movement of the jaw. And when there is synkinesis between the internal pterygoid and the LPS, upper eyelid elevates with clenching of the teeth. Severe winking with severe ptosis in Marcus-Gunn phenomena can be corrected by LPS extirpation followed by Frontalis sling procedure. Congenital neurogenic ptosis may also be found in Duane's retraction syndrome with elevation of the ptotic eyelid with movement of the eye. Acquired neurogenic ptosis can occur with acquired CN3 palsy and with acquired Horner syndrome. In acquired CN3 palsy, it is very important to rule out associated mydriasis. And in CN3 palsy, ptosis correction should be done only after correction of strabismus, because during correction of strabismus, there can be alteration in the height of the eyelid margin. Causes of neuromuscular ptosis includes myasthenia gravis and botulism, most commonly botulinum injection therapy for blepharospasm. In myasthenia gravis, the most common presentation is unilateral or bilateral ptosis, which is characterized by variability in the severity of ptosis over time and by fatigability, that is, increase in ptosis with sustained upgaze. Unlike in myasthenia gravis, in botulism, pupils are dilated because botulinum toxin prevents release of acetylcholine from presynaptic terminals in both nicotinic and muscarinic junctions, whereas in myasthenia gravis, only nicotinic junctions are affected by antibodies to nicotinic acetylcholine receptors. Mechanical ptosis can be due to mass lesions or edema. Mass lesions in the eyelid or orbit causing mechanical ptosis can be either congenital, such as plexiform neurofibroma, hemangioma, or dermoid. Acquired mass lesions causing mechanical ptosis can be any benign or malignant eyelid tumor. Postoperative or post-traumatic eyelid edema can also cause mechanical ptosis. Traumatic ptosis occurs following injury or surgery. Following eyelid injury, exposure of pre-aponeurotic fat indicates violation of the orbital septum and possibility of injury to the LPS, leading to subsequent development of traumatic ptosis. Traumatic ptosis can also follow eyelid, orbital, and neurosurgery. Following traumatic ptosis, aberrant regeneration can develop with elevation of the ptotic eyelid along with ocular movements. Following traumatic ptosis, adequate time, usually 6 to 12 months, should be given for spontaneous recovery, and ptosis correction should be done only after correction of any coexistent squint, as discussed previously. Pseudoptosis can be due to phthisis, microphthalmos, enophthalmos, hypotropia, dermatocalasis, and brow ptosis on the same side, or eyelid retraction in the opposite eye. Among the surgical options for correction of ptosis, LPS resection is indicated when LPS action is moderate to normal, as suggested by a 4 mm or more levator excursion from downgaze to upgaze. Frontalis sling or suspension is indicated for poor LPS function, as suggested by an upper eyelid excursion of less than 4 mm from down gaze to up gaze with good frontalis action. Muller muscle conjunctival resection is indicated for mild ptosis, which improves with 2.5% phenylephrine eye drops. And these are very important to remember. For ptosis surgery, local anesthesia is preferred to allow adjustment of the height of the eyelid margin as compared to the opposite eye, and only a 1 to 1.5 ml subcutaneous infiltration is adequate for eyelid anesthesia in most patients. The skin incision is made at the position of the existing or desired skin crease, and it should be at the level of the crease of the contralateral eye. With bilaterally poor creases, incisions are placed at the upper border of the tarsus. Maintenance of hemostasis is essential during ptosis surgery. Children with congenital ptosis causing amblyopia need earlier surgery. Otherwise, surgery for congenital ptosis is deferred till 3 to 5 years of age to allow for more accurate eyelid measurements. And in adults with associated dermatochalasis and brow ptosis, additional corrective procedures may be required along with ptosis correction. Indications for ptosis correction can be functional or cosmetic, and functional indications for ptosis correction include amblyopia, compromise of the superior visual field, or difficulty in reading. Relative contraindications of ptosis surgery include dry eye, reduced corneal sensation, inadequate Bell phenomena, and lag ophthalmos, and these are also very important to remember. Levator aponeurosis advancement or resection is done through a transcutaneous or external approach, in contrast to Muller's muscle conjunctival resection, which is done through a transconjunctival or internal approach. Levator aponeurosis advancement or resection is indicated in patients with good levator function, as we have discussed. The skin incision is made through the upper eyelid skin crease, and the primary purpose of this surgery is to reattach the LPS aponeurosis to the superior tarsus after resection of LPS aponeurosis if required. Patient's cooperation is elicited to obtain the optimal eyelid height and eyelid margin contour. The steps of the surgery are as follows. The skin incision is made along the existing or a desired skin crease. The orbicularis oculi muscle is incised and is separated from the orbital septum. The orbital septum is then incised, and the pre-aponeurotic fat lying between the orbital septum and the LPS aponeurosis is debulked. The LPS aponeurosis is then first separated from the superior tarsus and dissected from the Muller's muscle lying posteriorly. Partial thickness sutures are placed through the central tarsus and the desired level of the LPS aponeurosis. The desired level of the LPS aponeurosis can be adjusted by asking the patient to sit up. Aiming for a 1 mm overcorrection as compared to the normal contralateral eyelid is recommended. The sutures are then tied so as to oppose the desired level of the LPS aponeurosis to the central tarsus. The orbicularis is closed by sutures engaging the LPS aponeurosis so as to form the eyelid skin crease, and then the skin is closed. Frontalis suspension or frontalis sling surgery is indicated in patients with a poor levator function but with good frontalis function, as we have discussed. In this surgery, the eyelid is suspended from the frontalis muscle in the forehead, and following the surgery, the patient can lift the eyelid by elevating the brow. Some recommend bilateral frontalis suspension for unilateral ptosis because it provides better symmetry, but it subjects the normal eyelid to a risk of surgery. Materials which can be used as a sling for frontalis suspension include fascia lata, either autogenous or allogenic, or synthetic materials such as silicone rods. Autologous fascia lata has a lower recurrence rate of ptosis than either allogenic fascia lata or synthetic materials. When using allogenic fascia lata, the donor must be at least 3 years old, while slings made of synthetic materials are easier to readjust or remove. The steps of the frontalis suspension procedure are as follows. A lid skin incision is made at the level of the desired skin crease, and skin orbicularis and orbital septum are dissected to expose the LPS and the tarsus, as is done in the levator resection procedure. Then 3 forehead incisions are made, each 4 mm in length up to the depth of the periosteum, and these are made at the level of the superior brow slightly medial to the medial canthus, at the level of the superior brow slightly lateral to the lateral canthus, and 1 cm above the brow directly above the pupil. The middle of the sling is sutured to the central tarsus with the help of partial thickness sutures. Then the two ends of the sling are passed posterior to the orbital septum and anterior to the periosteum of the orbital limb and out through the lateral brow incision and the medial brow incision. Then these two ends are again passed through to the central forehead incision. The skin orbicularis incision is then sutured, forming the lid crease as described in the Levator resection procedure. The sling is then adjusted so that the lid margin is at the level of the superior limbus and the contour of the lid margin is acceptable. The two ends of the sling are then tied at the central forehead incision and the 3 forehead incisions are then closed. Muller muscle conjunctival resection, also called MMCR, is a transconjunctival or internal procedure and is indicated for small degrees of ptosis of 2 mm or less, which improves with 2.5% phenylephrine eye drops as we have discussed. And this procedure causes minimal disturbance of the eyelid margin contour. In this procedure, 4 mm horizontal width of tissue is removed from above the superior border of the upper tarsus. Alternatively, in the Fasanella Servet procedure, a portion of the superior tarsus is removed along with this tissue, and then the cut edges of the wound are closed with the help of sutures passing full thickness through the eyelid and tied anterior to the skin. Complications of ptosis correction surgery include undercorrection, which must be differentiated from postoperative edema, and de-operation for undercorrection is deferred for at least 3 to 4 months. Mild overcorrection can be managed with exercises in which the patient is asked to close the eyes and then manually pull down the eyelid while trying to open the eye. Other complications of ptosis correction surgery include lagophthalmos with or without keratopathy, change of refraction, particularly change of astigmatism, asymmetric eyelid margin height, poor eyelid contour, asymmetric eyelid skin crease height, tarsal eversion, conjunctival prolapse, wound dehiscence, scarring, and implant extrusion in case of Frontalis sling procedure. Thank you for listening.